Welcome, everyone. Thanks to all participants. My name is Daniel Goldberg, and I'm the moderator for today's session on crisis triage and people with disabilities, historical lessons for a time of COVID and coronavirus. We have several panelists today. This is a product of the Colorado Center for Bioethics, especially marking Holocaust, Genocide, and Contemporary Bioethics program. As you can see there, we have a number of panelists who I'll be asking to introduce themselves. One note that I wanted to address is that we will actually, unfortunately, not be joined by Lisa Iazzoni today. Dr. Iazzoni actually explicitly asked us to share the reason for her absence from today's panel, which ordinarily, of course, we would never do. But she explicitly requested that we do that. And the reason she's unable to join us is because her best friend, who is quadriplegic, was infected with coronavirus disease by a personal care assistant who did not have adequate access to personal protective equipment. So this is, of course, an enormous problem in the disability community receiving home-based care. And for that reason, Dr. Iazzoni wanted us to explicitly mention it, given the content of today's panel. So with that being said, although I'll be serving as moderator, I'm going to turn it over to the director of the Center for Bioethics, Matt Wynia, who's going to be framing the session for us and explaining a little bit more about how this connects to some of the Colorado Center for Bioethics activities as they relate to disability rights and history in particular.
Thank you so much, Daniel, and welcome everyone. Thank you for joining us today. We do at our Center for Bioethics and Humanities and across our university a set of programs each year during the days of remembrance of the victims of the Holocaust. This is an 8-day commemoration, started in 1979 when it was declared by the United States Congress to be the week of remembrance of the victims of the Holocaust. And we spend our time largely reflecting on the ways in which medical participation in the Holocaust continues to influence the ways that we think about and handle issues in bioethics and health policy today. So I'm going to spend a few opening minutes talking about the history of the community of people with disabilities during the wartime and in the years leading up to the war, as a way of recognizing the way these stories continue to affect our lives today. I do this knowing that there is always some risk in speaking about a very deep and difficult history too briefly. And there is also a risk in making any kind of a glib comparison between what happened in the Nazi era and anything that is happening today. Over 250,000 people with disabilities were murdered during the Nazi regime, and there is no real comparison to what we are experiencing today. It's a different type of crisis, and the roles of health professionals are very different today. And yet, understanding this history is critical to understanding some of the concerns of people with disabilities today, and it's critical to understanding how we think about it, even though much of the way that we think about this is sort of layered into a historical understanding that that may not even be apparent because it is so deeply embedded in the way that we think. And the history here really starts well before the war and well outside of Germany. Many of the people on this call, I apologize to, because I know you're really experts in the entire field of eugenics and history, and I'm going to go through this way too quickly. But eugenics was not born in Germany, and the first uses of eugenics in policymaking were not in Germany either. These are the states in the United States that had forcible sterilization laws in 1937. And I'll note, by the way, that while Colorado, our home state, did not have a law enforcing or encouraging sterilization, this did not prevent people in Colorado from being forcibly sterilized. There's a very well-known case, a woman who took on the pseudonym eventually of Lucille, who in 1941 was forcibly sterilized at the Colorado State Psychiatric Institution in Pueblo. And she was so traumatized by this experience that later in her life, not only did she take on this pseudonym, but she tore up all the pictures of herself in a way, trying to negate her entire existence. This is part of a really powerful exhibit that we're showing in our art gallery right now, which unfortunately, of course, is closed, but we're hopeful that we will get this reopened soon so that people can be in there and see the amazing Daisy Patton exhibit, Put Me Back Like They Found Me, which is about American eugenics. Hitler and his followers believed that what they were doing was what they called applied biology or applied racial science. And he called himself the doctor of the German people and believed that what he needed most of all was for doctors to be on board with his program of trying to create a master race. One of the first things that the Nazis did when they came to power was to adopt a law very similar to the American laws, which allowed for the forcible sterilization of people with a variety of illnesses, many of which would not even be recognized as an illness today, like hereditary feeble-mindedness. And this was quickly followed by reflections on their part of the idea that not only should people not have babies if those babies were going to be genetically inferior, but people who were already born and who were taking more than they were giving to society, who were, as I said, life unworthy of life, should in a sense not be around anymore, and in the end should be murdered. And the justification for this was entirely what you would call strict utilitarianism or harsh utilitarianism. The idea that people are only worthy of living if they are giving more than they are taking from society. This shows up in high school biology textbooks, and it's very much a blending of what were then thought to be biological rationales as well as economic rationales. And so the forcible sterilization program led rapidly to a program which became the Nazis' first mass murder program, which was called the Child Euthanasia Program. I'm putting euthanasia in scare quotes here because these were not by and large children where the parents thought that the babies ought to be put out of their misery. These were largely parents who were tricked into sending their disabled children to so-called special treatment centers. And in those special treatment centers, they would be either, sorry, I have to let the dog out. Too much noise. They would be either starved to death or sometimes killed through injections of lethal medicines. Between 5,000 and 7,000 children were killed in this way in the early years of the war. And the program evolved to become what we now call the T4 program, which was started on September 1st of 1939 with Hitler's explicit authorization. Many of you will recognize that date as being also the date of the invasion of Poland. So this is the official start of World War II. And it's important in the sense that, as Karl Brandt, Hitler's personal physician, later would claim, the Fuhrer believed that killing of disabled people would be easier during the crisis of wartime. This program entailed finding people who were often suffered serious disabilities, but often did not actually suffer very serious disabilities, but were thought to be unable to work and to contribute to the war effort. And as a consequence, they would be sent to these specialized treatment centers, which were, as they call them, Euthanasia Centers. These were actual hospitals, often psychiatric hospitals. And in the basement of these hospitals would be a facility where people who were targeted for killing would be brought. They would be asked to strip down. They would be tricked into going into a gas chamber under the guise of it being a shower. They would be killed using poisonous gas. And then they would be taken out. Their dental gold would be removed, and then they would be burned in specially designed gas or crematory ovens. And of course, if that whole process sounds familiar to you, it should, because the protocols, the types of ways in which people were tricked into going into the gas chambers as though they were going into a shower, the specially designed crematory ovens, all of those were adapted from the previously existing euthanasia centers for disabled people, and then used in the mass killing centers of Auschwitz and the others in the Reinhardt camps. And the historian Robert Proctor believes that the ultimate decision to pursue a program of mass gassing of European Jews, Roma and Sinti and others emerged from the fact that the technical apparatus, as well as the non-technical apparatus, existed in the so-called euthanasia programs. Moreover, there was a brief period in 1941 when the euthanasia program was halted by Hitler because there were people who were protesting it within Germany, most notably in the church communities. And during this time, the people who had been proven loyal in the T4 program were out of work. And some of them were sent to the Reinhardt camps to become leaders there. This is Dr. Imfried Eberl, who was involved in the early T4 program and then became the commandant of the Treblinka extermination camp. Treblinka is the camp where the Warsaw Ghetto was evacuated to, and over 900,000 Jews lost their lives in Treblinka. This is not merely sort of historical revisionism to say that the medical participation in the war was critical to the entire effort. In fact, Dr. Andrew Ivy, during the Nuremberg trial in 1946, said that if the medical profession had taken a strong stand against the killing of disabled people before the war, it's conceivable, in his view, that the entire idea and the techniques of death factories for genocide would never have happened. So there's a very strong connection between the experiences of the murdered people with disabilities during the Nazi era and the subsequent Shoah. I'll just close with the reflection that this is history, but this history is not gone. As Faulkner said, it isn't even past. It still very much influences the way that we think about bioethics issues in medicine today. So much so, in fact, that I think many times we don't even realize how influenced we are by this history. So the Colorado Crisis Standards of Care Plan, which looks at what we would do if, as a state, we were experiencing extreme shortages of things like ventilators and critical care beds. And in this document are a number of places where it very explicitly says we would not consider disability status as being ethically irrelevant to a triage process. That said, these issues are complex and difficult because people do believe, by and large, that when it comes down to allocating scarce medical resources, there needs to be some decision-making process that takes into account what is the likelihood that the person receiving this scarce resource will derive some benefit from it. And the question becomes, how do you define that benefit? So this is the current point system that's been recommended in Colorado, and it looks only at near-term survival. That's different from some other protocols around the country that try to look at long-term survival, which is much more difficult to predict, and also which starts to get into problems with people who have underlying disabilities, such as, for example, Down syndrome, who do have shortened long-term survival on average. And so if you start trying to predict who's going to live 10, 20, 30 more years, number one, it gets much more difficult. And number two, it becomes much more difficult to say that scoring system will not disproportionately affect people with underlying disabilities. So that conversation really went into our discussions about how to generate the Colorado Crisis Standards of Care document. That said, even what we've done, I think, will not leave every person with a disability satisfied. That we've gone far enough in removing consideration of disabilities from our protocols. And I just put up this quote from the American Association of People with Disabilities to say that there are those in the community who believe that really the way to allocate resources is first come, first served. And that the relative likelihood of that anyone would benefit from a service should be not considered when making allocation decisions. And I just put that up because I think, while I don't think that's the majority view, even among people with disabilities, but it is a view, and it's a view that deserves serious consideration and respect. And I'll close with this, which is a slide that I used in a presentation last week to our medical grand rounds. There is an underlying, very fundamental challenge with any scoring system that looks at who's likely to benefit from critical care resources. And that is that a perfectly accurate predictive score could disproportionately end up removing some people from consideration for ventilators and other critical care resources because they are less likely to survive. So a purely clinical predictive tool will disadvantage people who experience higher frequency and higher severity of comorbid conditions. The problem is when those frequencies and severities are a result of underlying historic, economic, educational, housing, other types of deficits and structures and stressors, that is the definition of a structural disparity in health outcomes. And so the question becomes, what can we do? Because we're quite obviously, we're not going to fix all the structural inequities in our healthcare system during a pandemic. And I think what we should aim to do at minimum is to make sure that those structural disparities are not made worse during a pandemic. The way we do that is by being transparent about our processes, about being inclusive in the development of these processes, by including very clear statements about the values that underlie treatment triage protocols, and by trying hard to avoid implicit bias. So we do this in Colorado by ensuring that the reviews that take place are blinded to information that is not relevant to the triage decision-making process. So if someone is in a wheelchair, the people making triage decisions would not know that because that's not relevant to the triage decision-making process. If, on the other hand, the person has heart disease or underlying lung disease with severe lung dysfunction, that would be known to the triage decision-making process because those factors are important for judging whether that person is likely to get any benefit from the resources. And then the last thing we have to do is track our outcomes and be ready to make adjustments. The protocol that I alluded to just a minute ago in Colorado, just in the last week, has already gone through a couple rounds of revision, and we'll be bringing it forward for approval for those revisions in the next few days. So thank you so much again for joining us today, and I look forward to hearing next from Julie. And Julie, I actually forgot, I was supposed to introduce myself, but I'm going to assume that by now anyone who didn't know me has Googled me and knows who I am. But would you mind introducing yourself and letting us know where you came into this conversation about triage and crisis standards of care?
Sure, thank you. My name is Julie Reiskin. I am the executive director of the Colorado Cross Disability Coalition. And what cross disability means is all types of disabilities. So we are run by people with disabilities, whether that means someone uses a wheelchair or they're blind or they have a developmental disability or they have schizophrenia, all disabilities. So that's who we are, and our mission is very broad, and it's to advocate for social justice on behalf of people with all types of disabilities. We are a Colorado-based organization. So where did, and we do a lot of work on healthcare issues in the state, mostly in the Medicaid system, but not exclusively. And we also do a lot of work on equity issues. So, so I was asked to talk about kind of the historic distrust people with disabilities have and what it would take to have people with disabilities trust in a system like this, and how, and I'm, to be honest, not, I don't, you know, like all of this long time ago, which was I think a month at this point, don't remember exactly how we got involved. I know that we did get invited in. We work very closely with the Polis administration, and got invited into some of these discussions. So why the historic distrust? I think you just saw a good reason for that. I heard the term recently, genetic memory, and I think that's really a fascinating concept, because I think sometimes people feel something's wrong even if there isn't something explicit or obvious. When you live with a disability, and one of the interesting things for me about being on all of these Zoom calls is that I have a disability, but you can't see that just from looking at the top of me. So I do use a wheelchair. But you know, it's not uncommon for us to have people coming up to us and saying things like, "Oh, I'd rather be dead than be like you," or you know, or people assuming that our quality of life is awful, when that, you know, may or may not be the case. Most people I know with disabilities have a good quality of life. And when they don't, it's because of the same things that all of us have problems with. Someone might be going through a painful divorce, or they might have, you know, just lost someone close to them, and then their life isn't happy right then. That's no different than it is for everyone else. That there's nothing about disability that causes our lives to be bad. Usually when people are frustrated, it's because of systemic, what we call ableism, and systems that exclude us. There's a lot of poverty in our community, but that's more because we don't get good education and are often the last hired, first fired, so we have a lot of unemployment, low expectations, etc. Those things absolutely cause problems, but that's not really because of our disability. It's more societal beliefs around disability. I wanted to make sure to mention kind of the intersectionality of disability, and particularly race. If you look at anyone who looks at health outcomes, people with disabilities, particularly people who are Black or Native American, have much, much worse health outcomes, even when you account for disability. People with disabilities in general have worse health outcomes, a lot of health disparities. Again, even when you control for disability, like we don't get screened as much, we often don't get primary care. And then if you add race to it, it's that much worse, because it's often the race and the poverty. So the experiences in the healthcare system that most of us have don't lead to trust. And again, that's particularly true for people of color with disabilities. They often have pain undertreated. And again, that goes back to a lot of implicit bias and some explicit bias of people thinking that certain racial groups are, or that they're going to abuse drugs, so therefore they shouldn't get access to pain medication. Symptoms are not taken seriously. You know, the worst is often assumed, and then poor outcomes are often blamed on people. Like we often say that people who have a high degree of high blood pressure, that's because of their diet, not because they're living with racism every second of their lives. So when you add all of that, and then also people with disabilities often are in some ways undertreated and in some ways overtreated. People are often overtested when they have with certain disabilities. Sometimes it's because there's curiosity, sometimes it's because people don't know what to do and they over test. And also it's because of the belief in some medical systems that we need to be fixed. And a lot of us don't believe that we need to be fixed. We might want management of certain symptoms. We have kind of a love-hate relationship with medical people because we have to go to medical people to get needs met. So for example, and again, this is all due to bureaucracy. Like we need a doctor to write the the letter about our wheelchair. It's not like most doctors don't know why a Mark IV versus a Mark V controller, which one is better. Most doctors don't even know, what's the difference between a solid versus an air tire, and why one, you might want one over the other. But the insurance systems make us go to doctors for that. So in everything else that we need, most of which is not medical, it's all paid for by Medicaid. So we rely on doctors for a lot. But then we also, there's that kind of medicalization of our lives that can be very frustrating and also very damaging. So when we talk about, one other thing I wanted to say about the intersectionality and both racial and class disparities, that's why I strongly believe that first come, first serve is very not the way to go. It's not fair, because what that does is it biases towards those who know how to access healthcare and can get there first. People with transportation, people who live in a zip code that's going to have fast 911 service, people who are going to who speak English well and who can speak well and fast, who are going to be taken more seriously. So first come, first serve, I think, is super dangerous, and it does not help. It helps those with the most privilege, and that's it. We would be very much opposed to that. I was asked to talk about what it would take for us to trust the healthcare system in this. Number one, involve us. When I got invited into these conversations, we were very, very worried. When I actually got to participate, I got a lot less worried. And then once I was given permission to talk about it with my community, which was fairly early on, we were all less worried, because what I heard was not what I thought it was going to be. I heard medical people really struggling ethically and wanting to do the right thing. I saw some comments on the documents by doctors that said, well, people on ventilator, people who have a historic ventilator problem might actually do well because they're used to being on a ventilator. So don't assume that they're not going to do well. To be honest, I didn't expect that to come from medical people. So being able to see that it wasn't what I thought it was going to be was really, really helpful. And so then I could share that in my community. So involving us is the biggest way to gain our trust, so that we can, because what we think is going to happen is almost always worse than it is, because again, that's been our experience. When there's been rationing in the past, it's always been based on money. It's always been based on, it's more important for some insurance company to have profits than for you to live. This is different. This is like there genuinely isn't enough, not a false statement about being enough. So it's important for our people to know all of these facts, and unless we're involved, we're not going to. Second is policies. Have policies like what we have in Colorado that are enforceable. In Colorado, we have an executive order. It's not just guidelines. Guidelines are nice, but they're not enforceable. So like the blinded triage, no references to quality of life past or present. The other thing, when we look at healthcare workers as having priority, which I do think is appropriate, we need to look at the nurse's aide as much as the doctor, and that helps address racial disparities. And then finally, when we're not in a pandemic, and really all the time, having ongoing discussion, training on bias from race and disability perspectives, where we can all be in conversation and know each other. The way to reduce distrust is to have conversations and get to work with people. Again, we need to be able to work with medical people. They need to kind of see us in a light other than as a patient. And I think developing those relationships spreads into both communities, both, again, the disability community and all of the different segments, as well as the medical community. And that's how we start establishing trust and seeing each other's perspectives. So thank you. I hope I didn't go over too much.
Thank you, Julie. It was terrific. It was wonderful. I actually had a number of questions to put to the panelists in general, and Julie answered most of them in general. So I do want to remind the audience that if they have questions, we will have time for Q&A. So please feel free to use the Q&A box. I'll be curating those and collecting them for our panelists a little bit later on in the session. But now we want to turn to our next panelist, who's Govind Persad, and I've known Govind for a few years. I'm going to let Govind introduce himself and articulate some of the comments that he's prepared for us today. So please feel free to go ahead, Govind.
Great. Thank you so much, Daniel, and thanks to the audience and to Julian. Matt, I feel really lucky in some ways to be the last panelist because they've so nicely framed some of the issues that I want to touch on here. So just a little bit about myself. I teach also in Denver, but at the University of Denver, Sturm College of Law, rather than at CU. And my connection to this issue is working in health law and bioethics. So I teach healthcare law at Sturm Law, and I also co-authored a paper in the New England Journal of Medicine that proposed principles for thinking about allocation policies. And I think our principles, things like prioritizing health workers, avoiding quality of life judgments, are in line with some of the things that Matt and Julie both said. So what I want to talk about today is something with a little different emphasis, which is thinking about how some of these criteria in triage policies might stack up legally. This is an area I'm continuing to work in. I authored a piece that will come out in the Yale Law Journal's online section, and then I'm also co-authoring 2 pieces that are under review that are both co-authored with scholars who have disabilities, thinking about some of the disability impacts of these triage rationing guidelines. Before I get into my material, I wanted to underscore something that I think connects to the reason why Lisa, for instance, couldn't be here today, which is that these issues around triage and rationing, while I think they're important, they make some of the dilemmas we are forced into by coronavirus really stark. I think they're a small part in a lot of ways of the larger picture of how to save the most lives, and a lot of the ways that we could do that and that we could save more lives of people with disabilities don't have as much to do with these triage policies. So for instance, we could have more PPE, obviously. The federal government could do much more on that front. A couple other areas are undoing some of the weakening that we've seen in nursing home infection control regulations. In March, the administration had tried to weaken some of those, and I think it'd be valuable to have those regulations be stronger and more protective of folks. And another area, and this connects with Julie's point about intersectionality, trying to limit and regulate particulate pollution. So there's a lot of pollution in our Denver area we see, and we see some evidence from medicine that this sort of pollution is correlated with worse dangers from conditions like COVID-19. And so these are areas that I don't think pose some of the same ethical challenges as what I'll talk about. They're hard in a different way, they're hard politically. But if you think that we should, say, do more to have PPE or not have this degree of high particulate pollution, especially in communities of color, you can call your elected official and talk to them about some of those issues. And especially given what we're seeing now about, I think, hopefully, maybe not having to use crisis standards of care in some places, and also about the limited, sadly, efficacy of ventilators for all kinds of people. In some ways, even though I think triage is really ethically important, there's a lot of progress that can be made outside of this context as well. So I want to turn now to just a first slide that I have here that kind of walks through the what I understand the legal landscape to be. So I'm going to share that slide now. On the left side here, this gives some criteria that I and some other folks, Wendy Hensel and Leslie Wolf, who wrote a very nice article about this in 2011, criteria that we think are legal. And then on the right side, some that we think are not legal. And so I want to focus first here on quality of life criteria, because we've seen some of these in some states that I think had guidelines that were not ethical and were not legal. Ones that talked about, for instance, do people need assistance with activities of daily living as a criterion for access to a scarce resource like a ventilator. And I think those criteria, A, are not ethical, and also B, end up not being legal. Other areas, and I think these connect, again, both with law and with ethics, decisions that are unsupported by evidence or arbitrary. And this connects back to the point that Julie and others are making about medical professionals and Matt's point about needing to have the triage process be shielded off from factors that are not relevant. There's some evidence that we talk about in replies to letters for the New England Journal piece that if you put physicians under a lot of pressure, time pressure, there's evidence that that sort of time pressure, if they have to improvise decisions, leads to more racial bias. I don't know of evidence like that about disability bias. I would suspect that time pressure tends to lead to that as well. I would love to see somebody work on that issue as well, but that's why I think we try to underscore that it's important to have clear, developed guidelines in advance, triage teams operating on those guidelines to try to reduce the probability of bias. It won't necessarily, as much as we might try, eliminate that, but might reduce that. The flip side is on the left side, and this comes back to some of the letter that Matt looked at the start. There are some criteria that we think are legal that some groups might disagree with. So I think probability of surviving treatment, if that's based on genuine evidence, that's legal to consider, and I think also ethical to consider. And the same with considering if someone is, again, based on evidence, not based on stereotypes, likely to be on a ventilator for much longer, that's something that can be relevant. And the goal here really is going to be the goal of saving more lives of people with disabilities and people without. Some worry that saving more lives implies that some folks are less worth saving than others. I don't think that's right. I think if we give equal weight to saving each person, we should aim at this goal of saving more. And I'll come back at the end to say something about how we might try to align that goal with trying to be fair and give priority to people who are facing intersectional disadvantages. And we see that goal of saving more lives across COVID response. So postponing surgeries, for instance, can be really bad for some people. And that's something that we've had to do right now in a lot of states. But overall, it'll save more lives of other people. So these dilemmas, I think, are really hard ones that we face all the time, both in triage and elsewhere. I think it's also important to differentiate concerns that I think are really important about how to fairly predict probability of survival. Do we really have a good evidence base? From a different argument, there's the argument that probability doesn't matter. I think it's important to be thoughtful about whether or predictions are based in evidence, but I don't think it would be right to say that probability doesn't matter. I highlighted here in gray the area where I think law and ethics comes apart the most. I think law does allow the consideration of even longer term life expectancy, but not everything that's legal is ethical. There are plenty of things that are legal to do that aren't ethical, and I think there are good ethical reasons not to incorporate a sort of longer term prediction of life expectancy for the reasons that I think our panelists before talk about. So I'll say some things about why these are legal to consider. I think that the most compelling analogy is when you think about lung allocation. So another area where we allocate scarce resources in medicine. We consider when we're figuring out which patients should get a scarce lung transplant, their probability of survival and their short-term life expectancy. For example, if you have somebody with very late-stage pancreatic cancer, the American Cancer Society there predicts a 3% 5-year survival rate. That's something that's very, very different from whether somebody with some other disability that doesn't have those kinds of effects. A disability, say, like being in a wheelchair or being being deaf. And I think it's important not to have a view that all disabilities are the same or should be treated identically. I think this is an area where genuine medical evidence about differences really matters. A couple points, I think, more generally about advocacy that I think are important and pose challenges, I think, in triage that they don't pose in other contexts where we think about disability policy. Don't pose challenges, for instance, in working to improve infection control in nursing homes or working to reduce pollution. I think in general, the interests of people with disabilities are often going to be in alignment. So when you think about universal design policies for access to spaces. With the case of something like scarce ventilators, it's harder to have that sort of universal design because most disabilities don't affect probability of benefit from a ventilator. Most people with disabilities don't have metastatic cancer. Most people with disabilities don't have disabilities that mean that they would be any less likely to benefit in the short term from a ventilator than anyone else will. And so a concern and a challenge I have when I see some of the advocacy documents is that I worry about cases where advocacy might prioritize people who are more visible over those who have disabilities who might be less visible. So the same in response to the Colorado guidelines, people with metastatic cancer might be quite vocal about considering short-term life expectancy. People who might lose their lives if you went to first come, first serve or random selection, they might be less able to effectively respond to that kind of guideline. So I want to go to one more slide. I had said one, but I found one other piece of evidence that I thought was really valuable and I think fits with Julie's point about first come, first served. So this is a slide from a small study that was done in Texas and Maryland, looking at what the community valued regarding fair triage guidelines. This is a study done by somebody at UT San Antonio and Johns Hopkins. And if you look from the top to the bottom, this is what principles folks in the community thought were legitimate to consider. Most people thought it was legitimate to consider, will people survive their current illness? There was more disagreement about surviving the longest. There was even more disagreement about, this principle of fewest life stages is considering people who are younger and haven't had the chance to live for as many years. Value to others is prioritizing health workers. But even those are considered as relevant by a lot of folks, even though there's more disagreement. First come, first served. Some people support, but is majority rejected. Most people in these surveys rejected first come, first served, and even more rejected a lottery or random selection. And I think a big reason why, one is the reason, and some respondents said this, is the thing that Julie said, first come, first serve my favorite people who have greater privilege. And the other is that it just is likely to save fewer lives to go with a first come, first served or a lottery approach. I think there are a lot of people, a lot of options that might be better for people who are disadvantaged and better for people with disabilities than first come, first served, including the sort of triage system that we have in Colorado. I think there are other ways that we might try to give priority to people who are disadvantaged but can benefit. So I'm working with some economists on whether it would be possible, for instance, to sort of virtually allocate ventilators in a way that's geographically fair. So could you assign some ventilators within a hospital, say in one area, to give priority to people in an area that is poorly served by medical care? Is that a way that we could save just as many lives while working to sort of narrow and avoid exacerbating health disparities? So anyway, I will stop my screen share now, and I really look forward to thoughts and questions from the audience.
Okay, thanks, Govind. I really appreciate it. And again, this is Daniel. So we have about 17 minutes for Q&A, and the questions are sort of coming along there. And so we'll generally try to take them in order with, I guess, some moderator privilege as well. So the first question I'm going to ask our panelists is whether they're aware of any states or communities where the disability community has been discriminated against during the process of trying to consider triage ethics during this epidemic. So are there any examples that you all can point to where you think it really looks, smells, and sounds like disability discrimination?
Yes, several states have had to be, had civil rights complaints and suits. Arkansas, was either Arkansas or Alabama, now I can't remember which, but one of those states actually said, if you have a developmental disability, you will not be considered for care. They have dialed back on that since then. There was also in some state, in Pennsylvania, the governor put out this beautiful statement about non-discrimination. It was really lovely, and then had guidelines that were the opposite of that. I don't know of other states where there is as much inclusion, because it's not just in the crisis standards of care. The response to the COVID pandemic is much more than this. It's working with your state Medicaid agency on what's going to be in their waivers. It's working with the state Department of Employment. It's working, like one question that we gave to them today is the guidance for the safer at home, which is the step up from stay at home, needs to tell employers do they have the right to tell employees who are more at risk to stay at home longer? And similarly, if there are employees that are expected to go back to work, or if they don't feel safe, what protections do they have? That needs to be addressed. So in every area of government, there are policy issues, and I don't know of other states that are involving our community the way Colorado has. That's different than like out and out discrimination, but really not involving us is discriminatory. But again, those few examples I've heard of recently.
I want to highlight something Julie just said about it's relatively easy, unfortunately, to say something that sounds really good and then have a policy that in some way ends up contradicting that, partly because of this underlying challenge of wanting to try to save the most lives and recognizing that there are features of some disabilities that make it less likely that that person will be able to get benefit from whatever service it is you're talking about. And I don't have a way through that except to say, I think you have to acknowledge that and face up to it and be honest about it, because otherwise I could easily see people becoming disenchanted and distrustful of a protocol that looks like it's speaking out of both sides of its mouth, right? That says, on the one hand, we'll never discriminate against anyone because of a disability. And then when you look at the scoring system, you can name a half a dozen disabilities that are going to show up somehow in that scoring system and end up disadvantaging people with those conditions. And so
Right.
I don't think there's a way to completely get around that, but I just want to make a plug for open acknowledgement that is a fundamental problem of trying to create an algorithm, a protocol that tries to save the most lives. And I will say the one way that we have tried to work our way through this that I haven't seen a lot of other states do is we've been explicit in the goal of our protocol that it is actually not just to save the most lives. It's to save the most lives in a way that is also most conducive to maintaining a coherent, cohesive society, and a society where people can trust their healthcare system, and a society where we'll come out of the other end of this crisis capable of coming together and healing. Because if we have to make really tragic decisions, we're gonna have to be able to heal from those decisions afterwards. And that's not just about saving the most lives. It's about how you do that. It's about the inclusion. It's right. There's all of these pieces with acknowledging the difficulty, acknowledging the tragedy. They're more nebulous things, but I think I'm very pleased that our state didn't just say the only thing we care about is saving the most lives. We want to save lives in ways that will retain trust in the healthcare system, in ways that will allow us to come together as a community and heal in the wake of a catastrophe. And that's important to say, even if I can't exactly say, and these are the 6 things we're doing to facilitate that. Just to have that as the goal, as a broader goal, I think is important.
Right. We've also talked in the disability community that our goal should not and is not to say that we come ahead of other people. We just want an equal chance or an equitable chance to be considered fairly, but that we should not come ahead of nor behind other people. And that we know some of us do have disabilities that, quite frankly, would not make the cut. Because of the nature of the disability and possibly combined with age. It's an issue that our community has never faced before, because this is really the first time in history that we've had elders in our community. This is the first time people have actually lived to be old, and that's new for us. So it's something we're kind of figuring out.
Okay, great. I'm going to move on to another question. And it looks like, and I apologize to all of our participants, the questions are coming fast and furious now, and that's great, but we're looking at about 10 minutes on the clock, so there's no way we're going to get to all of them, but we really appreciate them all. So this question is says that unlike many other epidemics and pandemics, COVID-19 clearly has more serious and fatal consequences for people over the age of 65. And Julie, this goes to something you were just saying. How does that impact decisions about the future value of people just based on age? Can they be ethically separated?
Who did you want to answer that?
Oh, this is for any of the panelists. I know, Julie,
Anyone
you're
who
welcome to say
dares.
something. I know Govind, obviously, a lot of Govind's work is based on this thinking about value of people's lives at different points. So Govind may have some things to say about that based on an
I'm happy
age
to say
criteria.
a little bit about this. I guess I would say I actually reject the framing of the question because of the fact that it says something about future value of people. I don't think our emphasis here should be on saying that some people are more valuable than others. The question is, in an atmosphere where resources are limited because of some of the factors we identified before, there are people that healthcare may be able to do more good for than it may be able to do for others. And the answer to that may depend on the type of healthcare. So, for instance, I think in all of these cases, it's important to look to evidence, as much evidence as we have, and not to hunches or stereotypes about, oh, this person won't do well on this treatment because they have some type of disability, say. But if it looks like, say, in terms of evidence, people with certain types of metastatic cancers who are above age X don't look like they have a high prospective benefit from this specific treatment, then I think it's legitimate to consider that, while also maybe prioritizing those people, and we say this in the New England Journal of Medicine article, prioritizing them for things like if you had an effective therapeutic, if you had PPE, trying to keep them from getting the virus more than you might try to keep, say, somebody who's doesn't have those conditions or is younger from getting the virus, because we're unlikely to be able to do as much good for them if they were to get it. So that's how I would think about the question.
So I'll add just one quick thing, which is to tie this back to the community of people with disabilities. I think we see a kind of similar phenomenon sometimes where there may be a population level predictive value to something like age or lung function or cardiac function, right? Across a population, those are correlated with doing poorly, even if you get placed on a ventilator, for example. And yet there are people, and I would hazard to say it might be most people with significant disabilities who have at one time in their lives or another, or maybe repeatedly in their lives, beaten the odds. And so the population level value of a predictor of future benefit or benefit from something, there are going to be people who say, yeah, well, I'm 85. No one thought I would make it to 85 either. So of course you don't think I'm going to survive any further, but that doesn't mean I shouldn't be given a shot, right? And I think that is one of the reasons why people with disabilities can sometimes mistrust the healthcare system, because we've made predictions that failed to come true about how poorly they were going to do, right? And then they made it through. And I think the same can sometimes be said of people who are worried about age, that we just aren't good enough at making individualized predictions to say, you will not benefit from this, whereas you will benefit from it. And of course, there's always some truth to that, because these are all probabilistic. They're all estimates of who is more likely or less likely to derive benefit from a given service. So we will be wrong sometimes, and it's just a challenge in medical care across the board, but it really is highlighted when you're talking about scarce resource allocation decisions.
Okay, great. So moving on, this question is for the whole panel. Anyone, do you think it would be useful for crisis standards of care to be hardwired into legislation or in a state's medical practice act?
Sure, so I can speak a little to that. I think if they're good standards of care, yes, there are advantages to having them adopted in legislation. If they're bad standards of care, it'd be better to have hospitals be free to make their own policies. One advantage to having them enacted in some sort of uniform way across the state is it reduces the chance of there being differences in policies between hospitals that are either lead to arbitrariness or lead to people with more privilege trying to pick and choose hospitals that they think they'll have a better chance at. I think at the same time, the state standard of care should be mindful of the fact that different hospitals within a state are likely to have different resources. So the way to think about doing triage in a hospital in, say, some area in the western slope of Colorado that may have very few, say, ventilators or may have a shortage even of ICU beds, that might look very different than thinking about implementing a policy in a place like the one in the background of Professor Goldberg and Professor Wynia's picture, which is a much better resource center.
Yeah, I would agree with that. It would have to be there would have to be some room though. So for example, even as we were talking in Colorado and they were talking about like how much time you would need on a ventilator, the data started coming in that COVID patients take longer on ventilators. So like if what might be 14 days in other situations for COVID patients might be 21 days. So I think you would not want to have it so specific that you couldn't address specific pandemics or specific emergency situations. So it would have to be written really well. But but certainly it be of something enforceable in an executive order that is not just saying, here's what we think hospitals should do if they want, and let each hospital do their own thing. And you do have to account for differences in rural versus urban, of course. But there should be some way, but just a guideline isn't adequate.
Yes, I agree with that. And one of the things that we talked about at some length in the Colorado process was how to ensure that we didn't adopt what would become a regulatory straitjacket that precluded innovation and improvement over time. Because that's the other thing that's happening, right? Everyone, for example, agrees that you should probably use some kind of an acute physiology index like the sequential organ failure assessment tool as a way to determine whether people are likely to die in the very near future. But also, at the same time, everyone recognizes that the SOFA tool is not very good at this. So you wouldn't want to write into legislation, thou shalt use the SOFA tool and nothing other. Because we all know the SOFA tool is not good enough. We ought to be able to do better than that. And so in particular, if you come to an academic medical center where we do research all the time, we wouldn't want a regulatory environment that says you can't try to do better than the existing protocol, right? You ought to be able to experiment and develop new tools that maybe are better at predicting short-term mortality. As we learn more about COVID, we're learning things like, D dimers might be important and LDH might be important and your blood type might be important. And right, why shouldn't we be able to take those things into account when we're trying to determine who's most likely to end up dying, even if we put them on a ventilator? If we can say, your odds of survival are very, very poor, even if you go on a ventilator, many families will want to know that before trying it, right? Because most people don't want to die alone in an ICU on a ventilator. So I think we do want regulation, we do want equity, we want fairness across the state, and we need to retain the ability to innovate and to learn.
Okay, well, we have a lot more questions, but no more time. So I try to be very scrupulous about time, especially for our presenters and panelists, who I'm sure have other things they need to be doing. So I want to take the opportunity to thank all of our panelists, Julie, Govind, and of course, Matt. I want to thank all of the participants and attendees for joining us and for some of the excellent questions. A recording of this will be available We are recording this and we will make it available. I'd like to stress that the Center for Bioethics and Humanities is actively engaged in a number of different conversations with partners and collaborators like Julie and Govind. We take disability rights and disability studies very seriously, and we maintain a good cadre of expertise and scholarship using multiple lenses, including law, policy, advocacy, history, the health humanities, literature and medicine, public health, and social science techniques for measurement and assessment. So all of this is going on in the center, and we'd love to engage with any of you who are interested in the work that we're doing and learn from you and the work that you're doing. So again, I'd like to thank all of our panelists and wish everyone a good day and to stay safe in the age of coronavirus.
Thank you, Daniel.
Thank you, Daniel.
Thank you.
Thank you, everyone.
Thank you, everyone.